Start recording now. And then I'm going to make you the host. Okay, hello everyone. Today is August 4th, 2020. My name is Forrest Wilson. I'm here with Aaron Proietti. Am I saying that right?
That's right.
And we are wondering what the heck is going on with COVID. And this is our second sort of deep dive into the more than a soundbite perspective of coronavirus. Looking at it from a data perspective, a meaning perspective, meaning-making perspective, and sort of showing up with the intention to empower you to make meaning of coronavirus responsibly. And we're going to look at that from an individual perspective and a collective perspective. And that's about all the structure we have for this. So it's just going to be an emergent discussion. Aaron's got a bunch of data pulled up, and I'll kick it over to you.
Yeah, thanks. I love the idea of having this conversation, so thanks for putting it together. I've been fascinated, kind of in an unhealthy way, with coronavirus data since it started accumulating back in, when was that, February or March. There was a period of time where I was actually trying to build my own models, predicting the case spread and predicting the death rates and things like that. That's evolved into now just a genuine curiosity about the data itself and some of the limitations that the data presents, some of the challenges that the data can present for someone who's not comfortable with data and doesn't necessarily know where it's coming from or how to ask the right question to genuinely judge the integrity of the data that's being presented. I love that you mentioned sound bites, because we're living in this soundbite world. We read headlines in social media, and that's where a lot of us get our news, right? Not even clicking into the nature of the article, and we're getting it from that 8-word headline. So building this muscle for critically examining or pragmatically thinking about how to make sense of what's going on around us is really important. So I don't know that I'm much stronger than anyone else at this, but I have a lot of time to think about it, and I've played with it a lot. So hopefully you and I together can ask some interesting questions, can wonder about some things that perhaps others haven't put into words, or perhaps others were wondering and they're glad to hear that you and I are talking about it. So that'd be my goal for our conversation here.
Awesome. Yeah, it feels great to me. And just anyone who's listening, we invite you into this wondering experiment with us. If you watch this and have questions or insights or other sources of data we should look at, we are really into exploring perspectives and would love to hear from you, and hope you reach out.
Yeah.
Cool. So where do we want to start?
Maybe we could start by discussing where the data is coming from that is typically used and cited.
Great.
In the news or by politicians. There are a few sources that I rely upon, but they all have their different applications. So 100% data integrity in the case of coronavirus is very difficult, if not impossible, to achieve. Let's just look at the US alone, not considering how other countries are reporting. But from a state-to-state perspective, there are challenges just in uniformity of how states are reporting. Even within a state, you're going to get challenges with how different counties are reporting. You can imagine a county that has more affluence, more public health resources, has more time and more knowledge to apply to putting together really high quality data than a county which might represent an inner city overstressed hospital system where the public health priority is not creating great data for media consumption, right? The public health priority is figuring out how you're going to deal with the crisis that's going on. And unfortunately, that's where the vast majority of these coronavirus cases are. So that compromises the integrity of the data. If there was one really big failing of the US government that I would point to, I don't want to be in the practice of criticizing the policies that have been put out in front of us, but There's one, which is a lack of coordinated response on data layouts, data definitions, and data collection at the federal level. Because we seem to have such an interest as a society in these national level numbers, right? We all want to know the US case counts. We want to know the US death counts because that's, for whatever reason, that's what we latch onto. It would have saved probably a lot of time and energy if up front there had been some strategy for gathering data at a national level that would be useful for culling through, for hashing out, for doing cross-examination, cross-tabulations, but that data set does not exist. Certain states for sure are doing a better job at data collection than others, and so we can extrapolate some findings based on state level data. The major organizations that are collecting data are obviously the CDC is doing data collection. And from what I can tell, it's not data collection above and beyond what they typically do with reported deaths and morbidity, which is unhealthiness, mortality, which is deaths. They already have standard data collection procedures in place for any type of death that exists. So from what I can tell, they didn't have to do a lot. The CDC didn't have to do a lot to figure out how to collect coronavirus data because they had these pipelines built. But death data is tricky. So there is no requirement to report a death to the CDC. So because of that, death data can be very slow to appear. If it's a disease-related death, certain diseases, yes, there will be a requirement if it was known this disease caused a death that the CDC would get that information. And so at first, coronavirus may not have been in that category. Then when it enters into that category, then all the testing procedures change. And so the data starts to warp, even as we're trying to standardize it, the quality of the data coming in starts to change. So CDC has had its hands full. But it's done a fairly decent job. What it's really useful for, the CDC data that I have access to, and anyone has access to it, it's public data. We could talk about how to access the data before I get into the details. So CDC has a great website. I think it's just cdc.com/coronavirus. And then anything that they have there, can follow from there. For any data set they're putting together, they make it publicly available through what's called an API. That API can just be a download of raw data. Sometimes it's at the state by day level, which is maybe the most granular that they make it available. But certainly the data could be every single test, every single patient that's positive, every single death that has occurred. They could have a record in that data, but they're not making that data publicly available. What they're making publicly available is summarized data, generally at the state and daily or weekly level. So that's what I'm able to download as a layperson sitting in my chair in my bedroom. I can access that daily state level data, which is pretty valuable for seeing trends and understanding what's really going on. They publish mainly death data. There's not a lot of other data coming from the CDC, and their official death figures might lag some of the other sources, which will present unofficial death data. But when it ultimately all comes together, it will be more official on the CDC site because that's what they do. They track these contagious diseases and publish death data on them. So pretty good for nuanced analysis, for cross-tabulations with other, they have a regular report, for instance, which shows pneumonia deaths, influenza-like illness deaths, and coronavirus deaths all in one table. And that's the only source you're going to get that level of data is from the CDC. So pretty useful for some nuanced analyses like that. The next source, which is worth talking about, is probably Johns Hopkins. It's probably the most cited source in the media. Johns Hopkins, the medical institution, has taken a very impartial approach to collecting data. So there's really no judgment to the data, which is really cool to see. They will, from time to time, post a recommendation study based on their data, but generally it's in a different part of the website than just the data trends. It's really good for high quality, vetted, media ready data. So if you're a media outlet and you want a fair degree of confidence that what you're going to show on your television screen or in your Twitter feed is accurate, you can pretty much rely on Johns Hopkins for being the best source for that. Doesn't mean they don't make errors, but they're doing enough vetting daily, right? Every single pipeline of data that's coming into their source data is looked at daily. Every line of data that I see, again, it's at the state and daily level, will have a code so that I know where it came from. It'll have a grade, so they grade the data based on how high quality the data has been coming from, say, that county or that state in the past. If there's any anomalies, there's usually a note there that said, hey, wait a second, this reported number is lower than it was yesterday, so we're investigating that, and they'll be very clear about that. Then there are two big, I think if you Google coronavirus data, you're likely to stumble upon two big sources of data. One is called the COVID Tracking Project. The COVID Tracking Project was a volunteer kind of grassroots assembly of people who had an interest in data very early on, who started to just reach out to these various local level sources of US-based data and started to compile them. And over time, it's come to largely match the Johns Hopkins data because they're looking at the same data sources, they're asking the same questions of the data, and they're making the same edits and same types of backtracking. So sometimes they have to update based on historical stuff that has been changed. And they're doing the same types of things as Johns Hopkins. I find it's the best for the do-it-yourself data expert who wants to sit on his chair in his bedroom and then pull data. They've got some great APIs, and I can pull long lists of raw data. Again, I don't get it at the individual level. What I get it at is at these summarized by day, by state levels. Perhaps they have it available in other places that I haven't found yet. And then maybe the best known, if you're just looking for good, fun data to look at, is Worldometer. I think many of us who have Googled coronavirus data have stumbled across Worldometer. That's a great source for international level data. It's good for snapshots. So what is currently going on? What's the current cumulative trend? What's the current death rate? How does that compare to other countries? So it's been a really valuable resource, I think, for getting the data to be at the forefront of a lot of the conversations. It puts really well visualized, actionable data at people's fingertips that we wouldn't have had without them 10, 15 years ago. So really hats off to Worldometer and what they're trying to do. And those are the major data resources that I look at. There are a few others that I found that are really valuable, but generally they're pulling their data from one of those four resources. The World Health Organization also has data. I haven't looked too closely at it. But usually anything you'll see will have one of those four data sources cited. So any questions on that? What does that get you thinking about?
Oh gosh. Well, I guess maybe we could just explore a little bit the different sort of give a little bit of definition to what the different data points are.
Yeah, I can actually share my screen and take you through some records if that's useful, and we can talk about. Let me pull something up here. Close this out. Okay. Just got to get to the top of this page. All right. And let me format this in a way that is readable. Okay. So I will share the COVID tracking project. Like I said, that's the do-it-yourself data that I found pretty valuable. I tend to pull this about every 2 weeks. I don't do it every day. So I pull it into Excel, which is my tool of choice for formatting data. So this is what the data looks like when it comes. Actually, I'll show you what it looks like when it comes in. This is the raw data import. Okay, it's got a date, state, positive, negative, pending. But then they give this what's called a data book. So they help you understand as a user what is the data that's being shown in each one of these fields. The data book's in alphabetical order, so I take that raw data and I put it in alphabetical order so I can compare each of the columns accordingly. There's this word deprecated which shows up. It means it's outdated, and I tend to delete those fields as soon as that shows up in the data book, because they're always making improvements in how they collect and publish the data. but they don't always go back and take that old data out. Sometimes they'll just say, that's a deprecated field. You don't pay attention to it if you're looking at it now. So here's the raw modified data. We've got the data quality grade, and this is, again, in alphabetical order because this is how I make sense of it. Which data was collected, how many deaths occurred on that day, but you see there's multiple records in this case for the same day, right? Because there's different states, which I think will be way over here. Yeah, so each of the states has its own record every day. So again, they're collecting this from county level data, from state level published data, and then creating a single record for each state that they push out in this data set. How many deaths are there? Again, this is not always confirmed. This is confirmed or probable deaths. The CDC has a pretty strict guideline on that. They have recently issued, I think in June, they came out with new guidance on how to classify a confirmed or probable COVID death. There's certainly some conspiracy theories out there that all deaths are being counted as COVID deaths and such, but I tend to think that this is fairly accurate. I can't imagine there's a lot of doctoring of death certificates going on here just for the sake of getting it in this count. So how many confirmed, and this is the methodology approved by CDC, this column here, how many deaths have been confirmed. Then they have the daily difference, which is your increases. FIPS is just a state level code. What else is in here? Cumulative hospitalizations. And you'll notice not every state has that, right? So not every state is publishing hospitalization level data. And that can be very frustrating, particularly when at the outset of this pandemic, when we were talked about flattening the curve. And the flattening the curve was about limiting the hospitalization, the runs on our hospitals and our medical systems, right? But we still are in a position where most of these states, probably half or more, maybe half, are not presenting hospitalization data. Even if they do, though, you have to ask the question, what's the capacity of the hospitals to truly understand whether they are at or exceeding their capacity? And I don't have that anywhere in this data source. So really that, generally, if you want to look at that, you have to look at a state level. A great resource for that is the state daily press briefings, where a governor will sit up and say, these are the counties where our hospitals are overrun, that sort of thing. So there's 3 hospitalization fields: cumulative, current, what is the increase? 2 ICU fields, how many people are in the ICU cumulatively and currently? A couple more date fields. Then there's fields around viral tests. From what I understand, these are the PCR tests. So this is not your antigen or serological test. Actually, it would be antigen. So this would be PCR and antigen testing, not serological antibody testing. So how many negative tests are coming up? We've got positive tests. Actually, it looks like they've broken out the viral test from non-viral. Or they've just defined this as the viral test only. So they're not doing the antibody testing. They're not presenting the antibody testing results. So what else is interesting here? I guess that's it. So there's testing, hospitalization, death data, and total case count data. And the total case count data is interesting. Actually, this data source does not even say that. They will just have cases. What are the positive cases? In some cases, for some states, that is a unique individual, but in other cases, that is a positive test. So some states have not gone the extra step to deduplicate the records to say, Forrest, if you tested positive and you went to the ICU, you would probably receive a test every day while in the ICU. So you might actually get 5, 6, 7, 8 positive tests in the course of your stay in the ICU. Some of the states are still reporting those as 8 positive tests and not 1. Other states have gone, like Virginia, for instance, has gone the extra mile to say, you know what, we're not going to count all of those additional tests in our testing counts.
Yeah, so I feel like if we pause there for a moment, that really jumps out to me as something to pay attention to. And I'm wondering, do we know? So I guess just to repeat that back, what I'm hearing is that in some states, if you go to the ICU and test positive for COVID, let's say you're there for 8 days, you get a test every day and test positive every day, that counts as 8 new positive tests. Whereas in a different state, that they deduplicate the data, meaning that those 8 tests would still only count as 1 test because it's only 1 person. So there's this distinction between, in some states, positive tests are different from number of people who test positive, and in other states, positive tests are the same as number of people who test positive.
Yes, and in those other states where they've done that deduplicating, you can say those are the total number of cases. You can confidently say that they're actually measuring how many cases they have. If they're not deduplicating the data, they're not telling you how many cases they actually have. So they're overstating the case count.
Even though they use the word cases.
Yeah, and so that's where it gets confusing. Is
right.
Some of these, it's not necessarily the state using the word case, and that's where some of the problems start to get introduced. Anytime you're compiling data, you have to name the fields. And so, for instance, COVID tracking project has chosen to name the field positive cases, viral, right? That's the name of the field that they chose.
Even though above it says viral test completed positive. That's kind of amazing to me.
So above it, I pulled that from their data book. So I found that field here, and I pulled that description just so I had it in my data and I could see that readily available. But yeah, you have to make those choices when dealing with data. It doesn't make it good or bad. It's just a choice that they made, right? To label it cases.
Yeah, and so to me, what would make this a little more helpful is to distinguish between cases and tests.
Yeah, it seems like they're more interested in getting it to cases and not even talking about tests, which feels like that is the end game, right? You almost don't care about how many tests are done if we have enough testing capacity to understand how many cases are out there, right? So they're trying to just get to the end without showing all the work to get there. But yeah, you're right. We should strive to have that information of, at the individual level, how many times does each individual be tested, and then understand what the difference is.
Well, and if I'm understanding you correctly, like Florida is a state where they don't deduplicate, right?
I can check to be sure. I know it's always changing. I'll flip over once I find it here. I think I have.
So part of what I'm getting to is if some states are deduplicating and some are not, and you're hearing, like, hypothetically, you could have a state that's not deduplicating and people are going into the ICU for a week or 8 days and getting tested positive for 8 days, and we're hearing case counts are going up. In that scenario, the number of people with coronavirus from those tests is not going up. It's the number of positive tests is going up.
That's right.
And all those tests are coming from that one person.
Yeah, let me share. So COVID Tracking Project does a great job at the state level of showing kind of a dashboard view. And so since you mentioned Florida, are you able to see this all right?
Yeah. So
here's the Florida dashboard view, 491,000 total cases, and then how many negative and pending tests, how many currently in the hospital. Again, there's no data on hospital capacity. So if you want to truly understand if we are threatening the hospital capacity, that's where you have to go into kind of the Florida governor daily press conference transcripts and actually get that data. That's the only reliable source I've seen. Some hospital systems are starting to present that data, but it's not fully compiled in a place where someone like me has access to it at our fingertips. If you look at the details that COVID Tracking Project, so they make these updates. So if there's a data change, for instance, on March 21st, they change their methodology, and so their number of negatives jumped up. Fine, on March 26th, they stopped including non-residents. So you can imagine that's an area of duplication as well. If someone comes across the border and gets sick at a Florida in particular, wow. You've got New York and New Jersey residents who live in Florida in the winter, but are still New York and New Jersey residents. Are they being double counted anywhere? Who's responsible for counting them? Is it the locality? Is it the hospital? Right. So all these questions have to be asked and answered, not just asked.
Right.
Looks like May 15th, they said they've got both PCR and antibodies in there. Again, PCR is I don't even remember what it stands for. It's some DNA word, but it's the swab test.
Polymerase chain reaction.
Polymerase chain reaction. Thank you.
Polymerase chain reaction.
So that's testing for the actual virus present in your saliva or in your mucus. That's what it's looking for. Very accurate test, by the way. So that's almost 100% accurate if it's done correctly. So the people tested has come into question as of May 31st. It's not fully duplicated. So Florida's report states people tested on multiple days will be included for each day a new result was received. So they're saying, yeah, each test is in there multiple times. And they have not resolved that. So as of July 10th, there's no update as to any resolution on that. So when we look at, and we can actually look at Florida's, I think I have the pivot all ready to go. Let me pull it up. Florida. We don't want deaths, we want case counts. So bear with me here while I get the data ready. I don't think you can see what I'm doing, right?
No.
Okay. Why don't I show you what I'm doing? New share. So from that raw data set that I showed you, I've created what's called the pivot table, which is a way for cross-tabulating data. So I've got all the dates coming down the left-hand column, and now I'm going to put, I think it's the positive tests. Let me just go with positive to start with. We'll take a look at it. So here's your Florida chart, and I'll blow it up, make it readable. So this is cumulative basis. This is what their chart looks like. If we want to look at it not on a cumulative basis, I can take that increase number, put that in there, and get rid of the positive number. Take that out. All right, so there's their daily data. So this is going to have a lot of duplicates in it, particularly as the testing ramps up. You know, as they have the capacity to test the same patient 8 times in a row, that patient is going to show up 8 consecutive days in here. So has there been a surge in case counts? I don't know. Right. I can't answer the question. My hypothesis is yes, there has been a surge in case counts. Because there has been a surge in deaths, we can actually look at that. And the death data tends to be more accurate. Where's that? Let's see. Death, I'll just go full. No, that's cumulative. I want death increase. So death data is spiky, but you know, lately in Florida, they have seen a surge in daily deaths and increase every day. So it's difficult to know how much that duplication issue is actually contributing to skewing the data, if there's a skew at all. You know, it may just be a small percentage. So it's just difficult to know.
And at the same time, I guess on the death count, something else I'm curious about is, aren't there, each day that passes by, there are more new symptoms of coronavirus, right?
For an individual? Ask the question again.
I guess, yeah, like, I guess what I'm trying to say is, from my understanding, I don't want to ask this question. From my understanding, there are more symptoms. The symptoms of coronavirus, we're labeling more and more symptoms, in the sense that to me, the net for capturing deaths as coronavirus is getting wider.
Yes. So there's a lot of things that are in that question. So you've got, for the most part, this month, July into August, we now have the capacity to test anyone who is passing away in a hospital situation. So the degree of confidence in knowing that there was a COVID-related death has improved over time, right? So it's not just relying on symptoms. There's far fewer just probable COVID deaths being labeled today than there were maybe back in April, May, when the testing quantities were tougher to come by. That being said, to qualify as either a confirmed or probable death, CDC has issued some pretty strict guidelines. Now, I know in the media we see stories of counties who are counting deaths from car accidents and other things, in their COVID death counts. That's going to happen in any complex situation, right? You're going to have errors. You're going to have data entry errors. You're going to have clerical errors. You're going to have misinterpretations, and those things need to come to the surface to get fixed. So we're going to see those things. We're going to see these systemic issues of misreporting data that will get fixed over time. So the longer we go, the better that's going to be. CDC's guidance for a probable death actually requires a medical examiner to say that there was a fair degree of confidence that COVID contributed in a significant manner to the death of that patient, right? So even with a positive test, sometimes now they're not coming back as a COVID-related death. But it's still hairy, right? The car accident situation is interesting. So if someone has a car accident, spends 2 days in the ICU, tests positive for COVID, then passes away, is that being counted as a COVID death? I don't know the answer to that. But the car accident was not a symptom of COVID, to your question. But it does get really complicated.
Okay.
But they're getting much better, right? You would imagine after 6 months of processing these through ICUs, through hospitals, that the degree of confidence that COVID is contributing is getting higher. Now, there's one thing I want to show that's really interesting. I have it pulled up here. In case anyone out there listening to this is wondering whether there actually is any COVID going on, or whether all these deaths are just deaths that we're now labeling something else. There has been some great analysis done on, I think this is CDC. So CDC published this mortality surveillance data. They generally do this in flu season. So on the far left of this chart, what you're going to see is, can I pull up a little, I thought there was a way I could highlight things. Oh yeah, here we go. Spotlight. Okay. So in the far left, you can see that they tracked in 2018, there was a flu outbreak, influenza outbreak, that led to higher than expected seasonal deaths. So what they're tracking is pneumonia, influenza, and now COVID-like illnesses, CLIs. So they have ILIs and CLIs. And they track the expected level of these deaths over time. So they haven't gone and changed the expected level based on COVID yet. They'll do that at some point in the future. And lucky us, because they haven't changed the expected level, which is down here. Sorry, I wish this wasn't red. Here we go. They haven't changed the expected level down here. Sorry, that's a sloppy circle. We're able to see that the actual number of pneumonia, COVID, and influenza-like deaths are far exceeding the expected levels at this point in time. So even if COVID deaths are being misreported, there is still an incredible increase in the total death count in the US over this point in time. So these bottom numbers here, 10, 20, and 30, those correspond to the weeks of the year. So weeks 10 through weeks 30 of 2020. We've seen this tremendous spike in overall deaths over what we would expect in a normal year. So even if they're not all COVID related, the vast majority are. Even if they're not all classified as COVID, there's going to be some incremental deaths that were never classified as COVID, which are showing up there.
So what I'm hearing you say is that for people who are wondering, is coronavirus even a thing? Are more people dying? The answer is yes.
Yes, by far.
by far. More people are dying in 2020 than.
Yeah, in fact, I don't know where the number is, but I did pull a little slides. Let me share this as well. um, oh, wait. I need to stop this annotation. Sorry, I'm still learning here. Okay. Can you see my PowerPoint or not?
No.
All right, let me try it again. Here we go. All right. So the impact of COVID has been about 145,000 deaths in the US have been officially reported associated with COVID. Like we just discussed, that includes any death for which COVID was present or presumed the cause of death.
Mm-hmm.
On top of 699,000 deaths worldwide. This is as of today, based on Worldometer. When you look at that excess death study that I just showed you, what that's suggesting is there's been about 148 to 202,000 excess deaths in the US since February 1st. So it's good thing is it tracks to that COVID number, meaning we're catching most of them, but there probably is another 3 to 50,000 deaths that have occurred that were not labeled COVID deaths that probably were COVID deaths. And these are big numbers, right? These are not insignificant numbers. These are much bigger than bad flu seasons, which might see 30 to 50,000 deaths. Mm-hmm. The worst flu seasons since Woodstock.
And
so, 4 or 5 times worse than the worst flu season in the last 30, 40 years.
Okay.
So I like this excess deaths analysis. It really gets at, is there truly a risk of COVID? And the answer is yes, right? That people are dying of this. What it doesn't answer is, were these deaths just accelerated because of COVID? Are these people who were going to die shortly anyway, and COVID, the comorbidity associated with COVID, actually accelerated their deaths? And that's tragic, even if it's the case, but it actually is more comforting if the answer is yes, these were just accelerated deaths. Actuarial studies are now starting to suggest that maybe it is. But maybe most of these deaths were just accelerated, and we will actually go under that expected level of death for some time, eventually to catch back up.
Well, and the other thing that comes alive, though, the other thing that comes up for me is like if you look at 2020, this has been an unprecedented time in human history in terms of how we've organized ourselves collectively. And so I also wonder, are there any unseen implications of what's happened in 2020 that could be creating an uptick in deaths?
Yeah, this is an interesting question, right? So what are the second order effects of COVID, right? What are I had a good word for it here, bear with me. Indirect, is COVID causing indirect mortality, for instance? And morbidity side, again, morbidity is just injuries or hospitalizations, but mortality, are we actually getting an indirect increase in some other categories? Things like suicides, things like maybe auto accidents are down because of lockdowns, right? You're going to get these indirect effects. Mm-hmm. Overdose deaths, at least anecdotally, both suicide and overdose deaths are surging right now. The CDC the director of the CDC recently stated that those deaths are higher than any levels seen previously. And that's tragic for sure. It's certainly tragic. It doesn't mean that a policy decision caused it, though. Let's be clear about that, right? It's an indirect death related to COVID, related to coronavirus.
Yeah, it could be for a million different reasons.
Yeah, it's difficult to pin down why. The causation is really difficult to come by, other than coronavirus is the causation, because that's the new thing that's been introduced. But what are the complex decisions, layers of decisions that were made on top of that, which led to someone overdosing or someone committing suicide? It's going to be really difficult to ever pin that down on any single decision.
Yeah. I think it's a good question. I think it's a good question for anyone watching to be in, though. It's just the awareness of the context with which the data is happening in.
Yeah. The data itself will not show context, right? You're very right. It's not going to show what's going on in, is China hiding hiding some bigger story, right? The data is not going to show that. Did we know about this before February? I don't know, right? The data, that's not going to show up. Did we make the right national level policy decisions? There's no control group, right? We'll never know the answer to that. Local level decisions. A lot of this data doesn't get to the local level, and you have to pull local level data to understand what's different at a certain local level than at another local level. But again, there's no control group, right? We're not doing test versus control here to try to understand, has any decision actually made a positive impact or a negative impact?
Right.
So you have to really just paint this complex contextual picture, like you're saying, and try to understand it. Make sense, make meaning of it.
Yeah. So I guess I'm wondering, I'm just putting myself in the position of someone watching this and going, like, so what, right? So what do we do? What do I do individually? What do we do collectively? How at risk am I? That's a question when I reached out to people and started getting feedback. That was a very common question people had. It's just like, for me, whoever me is that I asked, like in my specific place, whether it's in the inner city of New York or in the suburbs of Virginia or out on a farm in Colorado, like how at risk am I here of something happening to me? That was a really common question. And how much is what I'm doing really impacting the whole, which are huge questions.
Yes. And they're important ones, right? And I think I give a lot of people credit for the amount of time and energy that they've spent thinking about those questions. When I have conversations,
Yep.
People are very well informed. They understand the nuances. They understand when there's political persuasion, on one viewpoint or another. I've been impressed at how pragmatically people seem to be approaching this, but that doesn't make it an easier question, right?
Yeah, and I think for me, the question is like, there's a sort of general understanding that as we alluded to at the beginning, the sort of soundbite media reporting here, the pandering, the sort of position taking is really oversimplifying an incredibly complex situation, and people are not finding support in the ways that we feel we need to be supported right now. Like everyone's kind of getting tired of the charade in the game for a blanket statement. And so I'm wondering, like, we're good at, what I know is we're good at deconstructing that. I mean, you and I could spend 20 episodes talking about how irresponsible the media is and all that stuff. But but I'm more curious into like, what is the story we can invite people into? And I'm fine with deconstructing in that. I just want to also construct something new on the other side.
Yeah. Where to start? I think that's important. This question of risk is really important. Am I at risk? Truly understand before we address responsibility, right? You have to truly understand what the risks are. We've heard a lot about this, but I know that the storylines have changed, right? As we've learned more about coronavirus, we've seen different storylines emerge. What's currently known to be true, I guess, at the current point in time, until it's no longer known to be true, until it's disproven, is that folks in older age bands with comorbidities are at a much higher risk of severe illness, critical illness, or death from coronavirus. This is very similar to influenza, except for the age thing, right? Influenza tends to also have a pocket of younger individuals that are at risk simply for being young and having not established a really strong immune system yet. But for whatever reason, coronavirus does not seem to be creating crisis situations in those younger populations. They're not going to the hospital very frequently. They're certainly not dying. You know, the death rate for those under 9 years old, I believe, is statistically 0, right? It's just not happening. We do see the stories, to your point about the media, when someone under 9 dies, we will see a story pop up because it's exceptional, because someone will click on it. And that's unfortunately the motivation often of the media, is to report these exceptional, sensational stories. But that's not the rule. In many cases, they're reporting the exceptions. And so how do we get access to these rules? There's a couple of resources I can share, which are good here. Let me find them. Let me start with California has done a great job with data. I'll start by sharing something I found in California once I find it. Well, of course. Where did I put it? Well, I brought it into my spreadsheet. I can't find it in my browser, but I have it in my spreadsheet. So let me pull it up there. So many of the states are not reporting case counts by age. For whatever reason, they're just not collecting that information. When you go get tested, whether or not they're asking you your age, it's not flowing through their data systems and ultimately coming out the other side as this person at this age, in this locality, with this race, has this positive result, right? That data is getting lost in many states. Seems that California is doing a fairly good job at tracking that data. So I have, for whatever reason, they're just taking a different tact. I don't know. That could be another podcast or another webinar entirely.
Yeah.
But here's what they've found. So in those less than 5 years old, or 5 to 17, 18 to 34, here's your distribution of cases. This is not over time, so this is a snapshot, cumulative right now, as of July, probably the end of the month, probably the end of July. I don't know that, in fact, when it's official. But you see there's a heavy concentration in younger ages. This has likely changed over time. Early on, it was likely the older ages that were getting infected, but as the population has gotten more restless, a little more reckless with their behavior, right, as the beaches have opened up, as the bars have reopened up, the younger folks are starting to get more infected. So what is that actually causing? Right, looks like in California, 60% of the cases are 18 to 49, but very few of the deaths. Right, so on a percentage basis, between 1.5% and 6% of the deaths are occurring, even though it's 60% of the cases. So I calculated what's called the case fatality rate for these. I'll blow this up a little bit. Let's see here. We'll just blow the font up. So there's a couple metrics of interest here. One is case fatality rate. Oh, that's too big, which means of all the cases that are reported, how many folks are actually dying. So in these cases, if you're below 34 in California, the case fatality rate is 0.1% or lower, which is far, far, far lower than influenza. Right, this is not, so the other metric worth knowing is called the infection fatality rate. So for influenza, you might see an infection fatality rate somewhere around 0.2 or 0.3%. Case fatality rate is always lower than the infection fatality rate because these are the only the known cases are in here. So the ratio here is deaths over known cases. If we knew all of the cases, we could do the infection fatality rate. And generally with influenza, that can be projected. With COVID, we haven't been able to do that yet.
And
As you go,
why is that?
There isn't yet a strong measurement of how many people within the population have been infected. So if you, in the absence of being able to test everyone every day, you can't confidently know the infection fatality rate. We do have, like we talked about before, the serological or antibody testing. But even that's pretty imperfect, that testing. If you've recently had the disease, it generally doesn't show up because you haven't presented the antibodies yet. So it has a really low positive, a really high false negative rate if you're really close to when you had the disease. So that test will not show the positive. Additionally, it has a fairly high false positive rate in general. For whatever reason, it shows something like 20 to 30% false positive rate, which means if you have 500 people positive, you're probably really only around 460 or 540 or whatever it is. So that it's difficult to know just who in the community has had this disease and how were they impacted by it. One of the interesting things is in these lower age groups, a large percent of them are asymptomatic. And that's something new for viral diseases that, from what I understood from CDC website, isn't common in viral diseases, that asymptomatic presentation is fairly high with coronavirus, particularly in younger ages. But they haven't zeroed in on what that number actually is. Is it 50%? Is it 20%? I don't know. I don't think anyone knows at this point.
And what that means is the number of people who have the number of people who have coronavirus and don't have any symptoms, that's affecting this how?
So that would actually be as you try to achieve, I'm sure you've heard this term herd immunity, right? So if truly having the disease produces immunity, which we haven't correlated that yet, even this disease is so new, there's not a fair degree of confidence that if you've had it, you won't get it again. I think that's the working hypothesis, but it hasn't been proven yet. So if we were to get herd immunity, that requires community spread, right? It would require people to contract this disease, 60 to 70% of the population to contract this disease and live through it, so that the rate of spread starts going way down, right? There's something called the R value, which is how many people does a sick person infect. The R value is much higher when your overall community spread rate is much lower, because anyone you come into contact with could potentially contract the disease. You could spread it to them. But when you have herd immunity, quote unquote, far less likely to spread it to others. That's why it's important to know that asymptomatic rate, even beyond that, not maybe some of them were symptomatic but were just never tested, right? If the tests weren't available early on, or you talk to a lot of people who believe they already had it, right? I'm sure you've heard that story 100 times from people that you talk to, but they weren't tested, right? I believe I had it but wasn't tested, right? I think a lot of people believe that.
Yeah, I believe I had it, and I haven't been tested.
And so we'll never know. And until these antibody tests are useful, right now there's no utility really. Does it really make a difference to you whether or not you had it? Right. I have a curiosity around it, but it's not going to change my behavior.
And there's potential downsides to getting the risk. There's a risk to going to get tested to find out. In my mind, at least I've made that story up.
Yeah, if you can contract the disease again, and you start to feel that you're protected, that you're immune because you've already had it. That could be dangerous. Yeah, for sure. And maybe you could be a carrier even though you've already had it. And so there's that risk that you're continuing to spread it through the community. But you can see these death rates for older individuals are much, much higher. If they had the disease, then 80 plus, they're dying at a 23% rate. And that's scary, right? So if anyone asking the question, am I at risk? If you're in this older population, really 60 and above, anything that's 2.7, maybe 1.3 is even scary, right? 50 and above. These are scary levels. It's a roll of the dice. Do you die from this thing, right? But what this doesn't show is the comorbidity story. This is really just age breakdowns. At the bottom here, I've seen a bunch of studies which assume that there has been community spread, that we are getting closer to herd immunity because people haven't been tested. Some current good working theories are that anywhere between 2 times and 10 times the positive test, the number of cases have actually occurred in the community. So if we assume that 2 times the California number has occurred, or even 10 times the California number has occurred in their community, and we also then assume that the deaths are fairly well stated, so coronavirus related deaths are pretty solid. So if we assume the same number of deaths but much higher infection rate, then our case fatality rate is somewhere between 0.2 and 0.9% for this disease.
Mm-hmm.
Far lower than what we heard in February and March, which was, we have this new disease, which is a 5 to 8% fatality rate. We're at a fraction of that now, which is great, right? That's great news to be zeroing in on that number.
Mm-hmm.
Some of the best estimates I've seen are the infection fatality rate is probably somewhere between 0.4 and 1% of the population. So this actually jives really well with that. What we have here then, if we look at the California population as a whole, 39 million, with the 9.3 million deaths, we have a lower bound for the infection fatality rate, which is 0.02%. So it's definitely not lower than that, because we do know that there's been 9,000 deaths, right? And this is probably our upper bound here, is this 1.8%, which is the current case fatality rate. So the IFR is somewhere between those two numbers. So we're starting to get there, right? This is good, good analysis. We're starting to figure it out. I'm not sure it changes my behavior. And that's maybe a question that people need to ask. At what point does that number change your behavior? I'm scared of any disease, which is 0.5, 1%, right? That's pretty horrifying, right? It's a roll of the dice, personally. So
Scared of any disease that's 0.51%?
That's 0.5 or 1%, death rate.
Okay.
If you contract the disease, particularly if it's an infectious disease, that's something you want to avoid generally.
Mm-hmm.
I think that's just, smart living if you avoid that. Now, that's the upper bound probably. The other part of the story is comorbidities. So let me pull up a great study I found from a company called Swiss Reinsurance. So it's an actuarial study. Where is it here? They entitled Unraveling the True Death Toll of COVID-19 for the purpose of pricing life insurance policies. So they have a really vested interest in getting this right. And it's a good read for anyone really interested in understanding some of these trends. But one of the topics is who are most vulnerable, and they found that men and the elderly and the chronically sick are the most possible, most at risk. So men, for whatever reason, are dying at a higher rate than women, even with similar age and comorbidity profiles. They have a ratio they call the hazard ratio. So this is how much likely are you to die from coronavirus if you're in this category. That's what the hazard ratio is. So if you're less than 18 to 40, it's essentially 0, right? So you're not any more likely to die from coronavirus by age. It's a little blip for 40 to 50, like we talked about with that California study. It's a little higher for 50 to 60. But if you're 80 plus, your likelihood of dying from coronavirus is, 15 times higher than it was before coronavirus. By gender, you see female at, I don't know what this is, 1%, males at 2 times higher. And they had comorbidities here somewhere. Yeah, here we go, underlying conditions. So which underlying conditions have the highest hazard ratios? Looks like if you had an organ transplant, protect yourself. If you have hematological malignancies, so cancer within the last year, hematological malignancies in the last 1 to 5 years, both are at high risk groups. So you want to protect yourself or others who are in those categories. Even greater than 5 years seems to be pretty high. Liver disease, stroke and dementia, other neurological conditions, other immunosuppressive conditions, kidney disease. Those are your comorbidities with the highest risk of mortality. Some of the others that you might think are high risk, blood pressure, doesn't seem to be as much of an issue, but it still is elevated, right? So, and all of these are pretty high numbers. They're on the order of a doubling of your risk of dying from this disease versus someone who's healthy, right? A 1x I believe a 1x hazard ratio would mean you're 2 times more likely to die than someone who doesn't have that, if that makes sense. Chronic heart disease, not as much as you would expect. Cancer greater than 5 years ago, not that much of an issue. Interesting, smokers seem to not have as much of current smokers seem to be better off than never smokers.
Oh, well.
I'm not suggesting to take up smoking. It comes with some other hazards. But obesity, as you might expect, has a higher hazard ratio associated with it. Oh, so 1 must be a regular hazard ratio. Okay, so 1 is a regular hazard ratio, looks like. Yeah, so that's the risk thing, right? Am I at risk? There's obviously more to it, right? Risk is not just the risk of contracting and dying the disease, but the risk of spreading the disease,
Yep.
the risk of getting sick from the disease, which isn't shown here, right? These are deaths. And certainly it's not fun to get sick from this disease from what I've read, from what I understand. So the risk extends beyond death, but I think that's the ultimate risk.
I guess I'm just looking at the time, and I'm just curious to me, there's like universes to explore here, right? So like, obviously I want to share this. I want to share this and see what it sparks in people who watch it. And I'm curious, like, where's your curiosity taking you now? Where do we want to go from here?
There's certainly some interesting questions emerging around school reopening, how this is affecting youngsters. What position should I take when my school district is making a certain decision? How do I approach that? I don't know the answer to that, and I'm affected by it, right? I've got 2 girls in high school who are starting their year remote. And I'm not sure how I feel about that. So that's something interesting to explore. There's the whole category of responsibility. So what is my individual responsibility? Not only of protecting myself, but to protect others, which is a real interesting line of questioning. And then public policy responsibility. What responsibility should the policymakers have, and at what level should that responsibility be wielded or be expressed? Good questions. I don't have answers for those, right? I'm just the data guy.
Yeah, and as we kind of talked about earlier, I don't think we need to claim to know as much as ask the questions. Like, I think that's the thing right now is collectively, I don't even think we know what questions we're in.
Yeah.
So much like spiraling happening that I think we haven't taken any perspective on it yet. So maybe that's what we can offer.
Another category is these narratives, right? Exploring some of the narratives that are present both in society, whether it's political narrative or media narratives, and just trying to understand whether there's truth to them, whether they're skewed, whether it's about PPE shortages or hospitalization rates or cooking the books or whatever it might be. Interesting questions to sit with, to explore whether there's motivations for someone to be nefarious with these things, or whether they're honest, misunderstandings and complexities that are presenting themselves. I like exploring that stuff.
Yeah, the one that comes up for me is from my understanding, health centers are still being paid a stipend for every coronavirus death. And that's a real incentive problem. Someone jokingly said to me, if every healthcare facility had a tax on it for every coronavirus death, we probably wouldn't have any deaths. Which shows the incentive structure, Um, I say that is a sad joke.
Yeah, it's a sad reality.
Sad reality, right? And it illuminates the truth of human beings respond to incentives.
Yep. Yeah, the system will respond, right? The frontline worker may not be affected by that incentive, but the reward mechanisms in the system, the amount of resources being applied.
Mm-hmm.
Yeah, I could see some
Yeah,
of that.
if from a systemic perspective, you just gave every hospital $1 million and deducted 6,000 for every death the hospital had, it would be a totally. I mean, the all you could just see immediately all the data would be completely different.
Well, then you have the incentive to get rid of the people before they die, so then they don't die on your watch, right? So
Yeah, yeah, or claim it was from something else that didn't have that tax penalty. The same way
yeah,
one could argue that some people who aren't dying from corona are being incentivized to be labeled corona because that gets more money into the hospital system. So
yeah,
it's not as much of a judgment as it is just a pointing to the incentive structure.
yeah, and it's something to explore. And that's where things like that excess death rate are pretty useful tools for understanding,
Mm-hmm.
well, there is something going on, regardless of whether someone's incentivized to report it differently. There at least is something going on, but
Yep.
we should still explore whether there's an incentive structure which is preventing good outcomes from happening.
Yeah, and I think that's where in our discussion, I mean, I can get so I'm wondering at what scope do we want to hit this on, because you can just zoom all the way in and zoom out and just climb up and down the ladder of perspectives. I mean, I'm curious from the global systems and institutions, public policy, balancing economics and health kind of perspective. Like, what are I guess one of the questions I'm in is, what are the gifts that the coronavirus is offering? What is it catalyzing? How is it inviting us to wake up to a new way of being? I mean, so many of the questions are problem oriented, and I'm really curious about the possibility oriented.
Yeah, what are the futures? And how do you prepare yourself for the possible futures? That's real generative if we can have that discussion.
Mm-hmm.
And then we can look at vaccines, we can look at the absence of vaccines and talk about what changes. We can talk about social norms and what could and should be not be part of social norms. We could talk about dating with coronavirus and the
Yeah,
fun stuff like that, right?
social life, like there's
Yeah.
this whole discussion around bars and restaurants reopening, and underneath that there's an economics question, right? Like, how can I mean, you see what happens in problem oriented consciousness, right? It's like, oh, we have this problem that's a pandemic, and then we shut down businesses to avoid the spread of it. But then if we shut down businesses, then we have to put everyone on unemployment, and that's a problem because the federal government doesn't have unlimited money. So we print $3 trillion, but we can't do that in infinity because then the money becomes worthless. Okay, let's go back to the businesses and open them up, but only at 50% capacity, and everyone has to wear face masks. But now that's going to increase the case count, and it's like, you know what I mean? Like it's a like if you try and solve problems, you get more problems. So I wonder, what do we want to create, or maybe I should say, what do we want to co-create with coronavirus?
Yeah, recognizing that there's different factions who would
Mm-hmm.
not respond to a universal recommendation around this is where we're going to take everything. So the co-creation is so important for that. It's,
Yeah.
what would satisfy these various factions? Where do they want to be? Do we have common ground among the red and the blue, or the old and the young, and the public policy, public official versus private sector? What are the common goals? I would love to explore that.
Yeah. So how do we get the different perspectives to the table, swords down, and talk? I've got a lot of energy for that.
Yeah, that's fun. yeah, I don't proclaim to have any expertise in that. So if we continue that conversation, let's bring in the people who represent those groups and
Would love. That sounds awesome.
not you and me. We can facilitate the conversation.
Facilitate, yeah, we can. Yeah, we'll bring in someone who's going into school and someone who's going into retirement. Bring in a big left wing, a big right wing, right? Let's bring in um,
A big government person versus a small government person, right?
a business owner and an employee.
Yeah.
And a labor union person, right? Like, let's get all let's just perspectives in. And
yeah, real interesting. I like it.
cool. Well, I'm going to watch this and reflect on it and see we can connect on where we want to go from here. I'm sort of in the moment. I guess I'm just checking out with like an amazement at the awe of like how complex this is.
Yeah.
Just the kind of like, wow, the wowness.
And yeah, it never ceases to amaze me that when I dig into the data, I come out with more questions than answers.
Right.
Any rock I look under, I find something. And
Well, and I think what a perfect place for us to start, because like, when are we just going to collectively like not know together? I mean, it's like everybody, everywhere you look right now, everyone's got an answer for everything and everyone knows what to do. It's like, are you kidding me? Like, when are we going to collectively wake up to like, we have no effing clue what to do right now? Like, this is totally unprecedented. We don't have the answers. We don't know what's going on. Like, can we just be in that together for a moment?
yeah. Good way to put it. I'm uncomfortable there, by the way, but yes, we'll be there.
Yeah, I mean, me too. And it's reality.
Yeah, it's where we are, so
Yeah.
you might as well just recognize it. Yep. Good.
Well, thank you for the brilliant screen navigation and data modeling and everything. That's deeply appreciated. I really enjoyed that.
Yeah, it's my pleasure. I could do it all day. I didn't show you the half of it, so I was just scratching the surface. There were just so many ways we could have gone that it was really just bouncing across the top. But anytime you want to go deep with something, I'm happy to.
Awesome.
But thanks for facilitating this conversation. It's an important one, and I hope that it's well received.
Yeah, agreed.